So this is an airborne focused pandemic plan, and I'm really going to be relying on this group to be providing a lot of feedback in here. This is a project that's kind of in the mid stages of being created. And so the feedback that we'll be garnering from this multidisciplinary group is going to be essential to its success. So a little bit of history. Uh, this is a presentation I did for the Politics conference on February 25th of this year. And so this airborne focused pandemic plan was birthed from the loins of the Politics conference. Basically, in February, I basically tried to figure out what lessons from the COVID pandemic we were not applying in current pandemic planning. And at that time, it was mostly just almost like a vibe-based presentation because I actually hadn't read through in detail a lot of the plans that had existed. But now that I have, I think this is all the more important. So, just with introducing the project, I want to make sure that I pay respect to the group that has been brought together to work on this. So, we've been meeting every Tuesday at 1 p.m. Eastern, and we've been basically talking through some of the concepts. Um, and I'd like to introduce the group right now. Vicky Beer, I think you've already had a chance to meet earlier today. So University of Wisconsin. Vicky, do you want to just reiterate your role here?
Yeah, as I said earlier, I'm a risk analyst and right now focusing specifically on clean air interventions, but also a big believer in proper respirator masks. So,
And she has shared a number of the articles that she wrote leading up to the COVID pandemic, that is even including a pandemic plan for Wisconsin. Dorothy Wigmore is on the road today. I don't think she's here. I'm just double checking. Um, she's a occupational hygienist out of Canada who has been providing a lot of the occupational hygiene literature that we're looking at. Rob Goebel, I think I saw you in the crowd.
Yeah, I'm here.
You
I'm
want to
Rob.
just introduce yourself?
Yeah, I'm Rob Goebel. I'm a research professor at Clark University. And like Vicky, I have strong interest in a risk perspective. I'm particularly interested in how people cope with uncertainty. And I'm very much thrilled to be part of this group that Joe is leading. I have a particular interest sort of in structural approaches. What do you do when in coping with a big threat like pandemics?
Goja Gasparovitz, I do not believe is in this meeting. She is an environmental biologist who had a real strong role in our province of Alberta, looking at some of the exponential growth factors and modeling. And so she's been leading some of the way on elimination versus mitigation, as well as some of the mask work. Joe Eastman, are you here, Joe? I don't know if I saw his name. Joe Eastman's another modeler who's been really key in doing some of the modeling work on um, mask impacts. And we'll look at a graph of his a little bit later. Chris Hilliker is a BC uh, advocate who's an educator and just a public advocate on COVID. Frank Blancaro and Vincent Brunch, I think you all know. Is it Blancaro or Blancaro? I don't even know, Frank.
Okay, it's Glenson. Thank you.
And with the
So,
WHM have been very key on guiding this process forward and making sure we're on track. A couple more thanks. Mike Osterholm kind of triggered me with his book, The Big One, which I read in the late fall, and it really reiterated some of the importance of this. And Yanir Baryam and the WHN Infection Protection Committee, a lot of whom are here in the group as well. So thanks to all of you for your feedback. All right, that's That's my intro. I know it's kind of split up to a 5 minute intro and then we're into the workshop, but I think I can bleed right in. Is that correct? Just keep going.
Yes.
So,
Go for it, Jeff.
yep. So people may say, why even bother with this plan? There's a lot of other plans out there. The WHO has one. I'm sure the CDC is developing one. I haven't seen it recently. I know that in Canada we have the PHAC plan. So what possible reason could you have? One of my favorite quotes, which maybe speaks to some of the challenges of the world is we have this other group, the CATC, Canadian Airborne Transmission Coalition. They said, we don't have the hubris to think we can develop a full pandemic plan. But I guess we do. And interestingly enough, in reading through all these other pandemic plans, it became clear why we have to do this. Because even though we're just a ragtag group of different multidisciplinary people, we're not epidemiologists or public health people. A lot of the things that we're going to talk about are missing. I don't think we're inventing any new concepts here, but I do think the compilation of these ideas into one plan is really key. So, one of the things that's clear is that SARS-1 and SARS-2 completely failed, and we're failing currently with Ebola. We have the Campbell report out of Ontario in 2007, looking back at the 2003 SARS-1 pandemic, that explicitly states that airborne transmission should be considered first and foremost in approaching any major pathogen, whether it's spreading rapidly or whether it's a high risk pathogen. We did not do that with SARS-2. And now we've had the UK COVID inquiry who's looked at this as well, and again has said precautionary principle must be applied. The failing to acknowledge airborne transmission and to utilize respiratory masks is a key failure. And yet we're still not seeing that happening with Ebola, and it's a repetitive pattern that we somehow have to break ourselves out of. We must have policy to fit existing reality, not try and meet reality, fit existing policy. Just to tell one story, when I met with the Public Health Agency of Canada, they said COVID could not be airborne because in order for it to be airborne, we have to have negative pressure rooms for all of our cases. And because we don't have negative pressure rooms in hospital for all of our cases, it can't be airborne. It's insane that that's the kind of logic that our people are our public health leaders are trying to fit. Blocking transmission pathway is the key to stopping spread, and I'm seeing this missed over and over again in these plans. Another story is when I was engaged with the group that was working for the World Pandemic Plan a couple of years ago. You probably remember there was a pandemic treaty that was being pushed forward. That treaty was 100% about surveillance, finding new pathogens, identifying them early, but then not dealing with the transmission. So great, you found the next SARS-3. So good for you as you watch it spread earlier through your community. Really, transmission needs to be hand in hand with surveillance. And finally, just looking through all these recent plans, the word airborne is not to be found in any of them except for, I guess, the last page of the PHAC plan. Masks are barely mentioned, never mind respiratory masks, which aren't mentioned at all. And so the plans that exist have not been successful in learning from the past. So here's what we're going to do now. I'm going to run through the 9 points of our plan. I'm going to go through them relatively quickly, and then we're going to stop and go back to point 1, and we're going to go through those 9 points again, but explicitly eliciting comments from you. I want you to see the package first, and then we're going to go through the individual elements. So point 1, acknowledge the role of airborne transmission. So by front and centering airborne transmission as the lead, value is not the right term, but kind of overriding theme, it will center all of the decisions that come afterwards. Couple of points. You can imagine if you tried to develop a sexually transmitted infection plan for syphilis, but didn't mention sex, you would fail. You know, you could even say it's adjacent. You could say uh, French kissing is the cause of syphilis, but unless you explicitly identify sex as being that element, you're going to fail in stopping syphilis transmission. And the same goes for any respiratory virus. Airborne transmission is key to these pandemic plans because it's quite clear that of the last number of pathogens of importance, and that would include SARS-1, MERS, SARS-2, H1N1, any future flu virus, they all have a component of airborne transmission. And you always have to do your protections based on the the elements that require the most resources. So we need to default at the beginning to airborne. So pre-pandemic, we need to work on improving the medical community's knowledge and understanding about this and how to prevent and mitigate airborne transmission. This still is a failure. I can tell you if I go into my hospital right now and there's a flu patient or a COVID patient, it will not say airborne transmission is the main method of transmission. So we need to institute respirator masks for respiratory virus protection in hospital, long-term care, and other medical and congregate settings. We need clear language campaigns for the public and employers about airborne transmission, its prevention and mitigation. The clear language point is quite important because right now we're using there's a lot of euphemisms for airborne transmission. Other terms that are being used are aerosol, which I actually have no problem with. I think aerosol is a good explanation. Inhaled is another way of describing this, but I don't think it's as clear. And then there's this new term coming out of the WHO called through the air, which really does obscure airborne transmission and can be mixed in with contact droplet, in particular droplet transmission. And in my mind, only aims to muddle the language. And then during the pandemic, we really need to up our language and education campaigns to explain this not only to the public but to healthcare workers. Number two, focus on respiratory mask protection. I mentioned this before, none of the current plans have respirator masks as a center. This is centered as number two item on our plan. We know that for airborne transmission, not only does it have to be inhaled into your lungs in order for you to get sick. If you prevent that, you don't get sick. But also you're exhaling those diseases, those viruses or bacteria into the air. And by having the dual transmission inhibition of the source and the receiving patient, the receiving individual of having a respirator mask, this can be an extremely powerful tool that really has not been utilized. So we need to improve our designs, our standards, Barry, and to also do better at the reusable elastomeric respiratory masks. And we need to ensure that we have the capability and rapid scalability in each jurisdiction for early use. In the pandemic, I think it's going to be key for our governments to be supplying these masks to ensure that the public gets them. The current recommendations in healthcare or in industrial spaces is to not reuse these masks multiple times, but for the disposable ones, I think if we're doing 300 million Americans or 40 million Canadians or other jurisdictions, reuse is going to be reasonable. Even better would be providing an elastomeric mask. They last for 5 years. They're only $35 to $40 at this point. That's a real impressive return on investments if we were to get one for each person at the beginning of a pandemic. So this is some of the modeling that's been put out. It's a bit of a complicated graph from Gosia Gasparovitz, but essentially, if you look, I don't know if you can see my cursor, but on the left side, we're looking at a uh, N95 style mask, which has about a 95% reduction in risk. And then the next column is the percent masks. And then the next column is the percent of R reduction. And then the top row is what your original RE is. So RE is the effective R rate. So if you have, just a reminder for those of you who aren't in public health or have forgotten, the R is the number of people that one person will infect. So if your R is 3, say this middle column, that's about where COVID was. It was probably 2.5 to 3. What percent reduction you'll get. And you can see that with a very effective N95 mask, you don't even have to have a huge number of the population masked in order to get an impressive reduction. So if 80% are masked, then you get a reduction from 3 to 0.63. Because of exponential growth and decline, as soon as you get below 1, you have exponential decline. And the lower below 1 it is, the faster that decline is. So some people will say, well, you're never going to convince everybody to wear a mask. Well, you don't have to. You just have to convince the majority of the population, and you're going to get an impressive reduction in your R. And then just to compare it with a procedural mask, which is the medical mask that you see, you remember the blue ones that were all through COVID. It's a lot harder to get below a 1 because the effectiveness is just not that good. So these are some estimates. Then we'll go to Joe Eastman's graph. So Joe, basically, this blue line at the top is an actual wave in 2024. And then he did an estimate. The different colors are the different percent of the population wearing a mask, an N95 mask. And at 95%, basically, well, actually, if you look at the green middle line, that is, I think 35%. So it doesn't take a lot to flatten that curve and to prevent it from going up again. So masks are incredibly effective and were underused in the pandemic. So number 3, focus on indoor space protection. We know that if we lower the amount of virus floating through the air, it does make a difference as to your risk for infection. And conversely, if you have really poor air quality, you're going to have a higher risk. So this means ventilation, filtration, sterilization with far UV light. This needs to be done in all public indoor spaces, including schools, work sites, restaurants. We need to improve these technologies. We need to figure out that balance. And I think Barry, you might want to weigh on this as to the cost benefit of some of these. There's some evidence that, say, for a single space, you can improve that ventilation through very expensive fans and heating and cooling of that air as it comes in from the outside. Or you can put in some far UV light into that space for a much cheaper cost. So what is that balance between these 3 tools? And we need to improve building codes. During the pandemic, we need to really escalate the assessment installation of these technologies. But this should be happening in advance. Testing. Testing, again, was probably underused through our pandemic. I remember going to COP, what was it, COP 25 in Glasgow, England, Glasgow, Scotland, and you had to test every single day looking for those asymptomatic infections, and that strategy wasn't applied at all in North America, to my knowledge. So those kind of either regular, like 3 times a week, no matter whether you have symptoms or not, or pre-event personal testing could be really improved. And wastewater testing can really help in identifying new infections in a space where you may not, as a public health system, actually recognize that the infection has started to percolate through your community. Number 5, and I think this is another really, really key component of our plan, is that there are staged societal mandates with transparent, defined thresholds for implementation and removal. That's a lot of words, but let's go through those at all. Staged means you're going from one level to the next. Society, these are all society areas, but we could make them geographical. We'll talk about that. Mandates, these are rules that people must follow. Transparent, defined thresholds. So everybody knows when and where these stages will be implemented and removed. And that's key. And that means that as a society, you can all be working towards a shared goal. And you all are, as these data points start to climb, you can also work to prevent other stages. So we really need to think this through. We need to have a really good sense as to what we want. I'm proposing at this stage, but or I should say, we are proposing at this stage that there's 4 stages. The first is just respirator mask and testing recommendations. The second is respirator mask and testing mandates. The third is closure of restaurants and public events. And the fourth is closure of schools and non-essential workspaces. Some of the things that we need to think about is that in the pre-COVID pandemic plans, the default was to go straight to number 4. You'll all remember on March 15th to 17th, 2020, everything shut down. There was no 1, 2, or 3. It was 4. Right? That was where we went to. And that had huge implications for society and for our economy. What if we never got to 4? What if the enactment of number 2 was enough to prevent any further progression of transmission? And although we've never done this experiment, I think that would be worth attempting to see if we can avoid ever getting to number 4. And then, of course, every single pathogen has its different elements, its incubation period, its pathogenicity. So once the pandemic hits, there will require to be adjustments to this plan, but the plan itself needs to be in place prior to the pandemic. So a couple more things that we need to chat about in regards to this. This idea of elimination versus mitigation. And I think you'll all recognize that during the COVID pandemic, the vast majority of the Western world, with some notable exceptions, tried to do mitigation. That means allow transmission to continue on in our communities, but not too bad. We don't want it to get too high or too low. There were a few exceptions to that, and I'm just going to focus on the Western world. We're not going to talk about too much Asia, but if you think about New Zealand, Australia, and notably in Canada, the maritime provinces all pursued an elimination strategy. We do not want to have this disease floating through our communities. And so there were strict quarantines. And if there were any start of transmission chains, they were huge efforts to break those down to go back to elimination. There's been a little bit of a debate in our group, and I'm going to open this up to this group as to whether there should be a focus on this. Initially, I was a bit resistant to that because there was a lot of pushback from the public health community about the COVID zero efforts. I think I've been convinced now that this is really important, and Yanir, credit to you for doing the simple math. There is no letting it percolate in society. Because in order for it to just be a smooth percolation, you have to get that RE, that effective R ratio at exactly 1. Um, and so one person infects one person, and that's almost impossible to do. So you're either doing um, exponential growth, but with an R of more than 1, which essentially is just a slow letter rip, or you're doing exponential decline, which is elimination. So, and there's lots and lots of economic evidence that those um, communities that pursued an elimination strategy had more success economically, societally, and health-wise. And so I'd like to hear people's opinions as to whether they think that this should be elevated to a higher level. Maybe it could be the 10th element. The next thing we need to discuss is which thresholds are going to be used. So is it going to be hospitalization rate, death rate, case rate, wastewater numbers, or percent positivity as to which thresholds will move people up the stages? This next concept also comes from Dr. Baryam and as well as others. So this idea of geographic flexibility or green zones or bubbles. This is essentially what the Maritimes did here in Canada or New Zealand or Australia did. They aimed for elimination, and they could have a different level of or a different stage of their societal protections than other areas. Like in New Zealand, people were going to concerts because there was no concern about getting infected. So these green zones are defined at areas with near zero pathogens and allowing lower stages. There would have to be some kind of um, uh, checkpoints getting in. Obviously, that's easier in a place like New Zealand where everybody is either flying in or coming in by a port. And as they enter into that area, a respirator mask and serial testing would be instituted rather than quarantines. If substantial community transmission begins, you lose your green zone status and you have to go up to a higher stage of protections. And this surveillance looking for wastewater infections, serial testing, you could do group testing as well, will be key to looking for the ongoing elimination from these zones. And it could be local, regional, provincial, or national. I'll just tell a quick personal story from my region. Um, we had a lot of anger coming from rural communities because once our urban areas started to become overwhelmed, so Calgary and Edmonton, smaller towns that essentially had no infections were put on the same stage of mandates. So basically, they were locked down, even though they had no community transmission. And that really resulted in a lot of societal disruption and still resonates to this day in uh, far right groups in particular, having an impact on our political systems. We need to avoid that. Number 7, vaccines and medications. I'm not going to pretend to be an expert on vaccine and medications. This is essentially not anything different than what is proposed in other plans or what happened in the COVID pandemic, but it is an acknowledgement by including it in the plan that this is important. We're not anti-vaxxers. We do want good medications to be going forward, and that once those vaccines, if we can actually develop sterilizing vaccines, that'll have a huge impact on the pandemic. We never achieved sterilizing vaccines in the COVID pandemic, but that just means we have to continue to work hard to get those. Communications, we're again kind of getting into the more general stuff. We do need transparent, honest communications of known unknowns and risks. I think this was a huge failure of our public health during the COVID pandemic. There was a lot of what's sane, not sane mongering. What's that? What's the word I'm looking for? But trying to avoid panic. Elite panic is one of the terms. Um, but
Mongering.
Calm mongering, yes, thank you. Trying to avoid calm or trying to put in calm mongering, whereas we have lots of scientific research that really the public just wants to be told what's going on, and have clear communication. We do need to have people other than medical doctors, other than public health people doing the messaging. We need to engage with community partners and certainly in my community, the local communities, the local pastors and imams were some of the most effective messengers in our neighborhoods. And the last thing is governance. Three really key points. Um, Multidisciplinary composition of these committees that was almost exclusively infectious disease and epidemiologists. In the last pandemic, we need to include aerosol scientists, safety engineers, occupational hygienists, sociologists, labor representatives, advocates, all of them, including the epidemiologists and infectious disease physicians. This is a multidisciplinary effort. The precautionary principle needs to be centered. There has been mention of it in the plans that I've seen, but just brief, undefined mentions of the precautionary principle. We need to really define what that is. We need to assure it applies in particular to transmission. And finally, equity. To the credit of the WHO and the Public Health Agency of Canada, equity is very much centered in the center of their plans. We agree with that, but we don't think that should be the only value that takes care of these plans. Just to be clear, there are some things that are included in other plans that we're not including. We're not talking about fiscal policy, which is income top-ups, eviction protection, sick leaves. We leave that for the economists. And that's a kind of a whole separate field. And also surveillance. Again, there's lots of work being done on surveillance. That is not the focus of our work. And then so where are we at? So what we're doing is we're going to be reading. We have to go through both all the pandemic plans that existed before, or as many as we can that existed before the COVID pandemic. We have to go through all the current plans. Then we need to, our plan is to do that over the next 4 to 5 months. Then we're going to start to write. We're still not clear and looking for advice from this group how to get this out into the public. Do we just want to put out a report and have like a 100-page report, or do we want to do a 20-page peer-reviewed journal article? And then I think as key as that is we need to get it out there and promote it, because what's the point of writing something that just sits on a shelf and doesn't get read by the powers that be? We do want it to exist though, because when the next pandemic comes, if our plan isn't instituted, if it's going to be the Public Health Agency of Canada or the WHO's plan, they are going to fail, and we want them to be able to reach for a document that can guide their approach differently. And so, just a reiteration that we're meeting every Tuesday. That's my email address. And now comes the fun part, where you guys get to give us some feedback, and we're going to go back to the beginning. So before I go into the individual elements, I'll just open it up for any comments. Are we crazy? Are we on the right track? And then we can go through the individual elements. How much time do we have, Frank?
About half an hour still.
Okay. So not a ton of time, but are there any, Frank and Vincent, you've been looking at the comments.
It's you take off the presentation so it's easier for people to see each other, and then you can call them out rather than.
Sounds good.
Yeah, Barry.
Yeah, so great presentation, Joe. Thank you very, very much. And as far as the format going forward, a peer-reviewed article sounds good, but I think really we need that 100-page report that actually gives the recipe for success. It gives you an alternate to what is traditionally done by PHAC or by, any individual traditional organization. And we need them to have an opportunity to look at that as an alternate to what they're doing in advance, when things aren't going crazy. And I think a well thought out program, they could consider at least some of the elements of that and bringing them into other areas. So I would support the 100-page report for sure. Thanks.
Thanks, Barry. I see a lot of hands now. I'm not exactly sure how to go in order. I can only see
I can help, Joe.
Osmar and Nicholas.
Yeah, I see the order. Let's go with Nicholas first, and we'll keep going down the line.
Okay.
Hi, Joe. Yeah, great presentation. So one of the things that I was thinking of just by sort of hearing you is I'm wondering if there was a possibility of, in a pandemic plan, of actually putting into place almost like a preventative measure, similar to what you would do if you were like doing like a fire drill for a building, for a school, where ultimately, we're talking about respiratory airborne protection, but maybe implementing that into almost like a punctual, make that almost like a punctual routine. And I think a good opportunity for that is when we enter traditional respiratory seasons in the winter, we have our public agencies sort of just further promote, sort of masking air as just sort of a necessary a regular sort of tool that we can use. Similarly, like people, have soap at home to wash their hands and wash their produce. And then hopefully with that, everyone would have like a little stack of respirators at their house, which means if ever there was an incident, we wouldn't have any sort of supply issues, but people could just pull out the respirator and they can, because we had a supply issue in Canada at first, which I think that's probably what also guided a lot of the early sort of guidance on airborne transmission.
Yeah, it's an important concept, and I guess I'll just reply that there are a lot of members of this community in particular that think we should still be all masking all the time. And certainly I've been a part of advocacy organizations that are recommending that people do indoor masking, in particular during respiratory season. I'm not sure how practical that is. I don't think it's an achievable goal right now to even get, a large number of the population to be masking. I do think we need to figure out how to make masking more socially acceptable, but that would be different than recommending masking for all people in public spaces. So again, interested to hear other people's perspective on that.
Sunil, please.
Hi, Joe. It was a great presentation, like always. Uh, no, most of what you said was based on the evidence assumption that everything will be successful. So we'll be able to mask and we will achieve this. How do you think if we take into account we fail on masks, we fail on this, we fail on this, what will happen? So maybe incorporating failure in all of your plans. So if we are thinking in those terms, because last time we failed, we couldn't do this. We couldn't use step 1, step 2, step 3 or 4. What will happen if we are not able to do it now again? What will happen then?
Yeah, so good questions. The first thing is I would say is we didn't try this. So this isn't something that we tried and failed. It's something we never tried. We just went to step 4. There were a lot of reasons why that was difficult, partly because locking down and hiding in your basement is really hard. We didn't talk too much in the presentation about schools, but schools are a really key element of society. They not only are key for childhood development, but they were also key to allowing people to be engaged in their workspaces, but allows parents to go to work. And so following the pandemic, there was a lot of people going, "Oh my gosh, we should never do that again." While at the same time acknowledging that a lot of community transmission originates in schools. One of the conversations I had with a prominent epidemiologist was whether kids could mask. And honestly, I think it'd be amazing to have a situation where the pandemic starts and all the kids wear N95 masks and we improve the air quality in those schools and we don't close the schools down. Remember, that's only on stage 3, where stage 2 is where we're really instituting a lot of these masking and testing protocols. Um, so, uh, so by doing things differently, I think we're setting ourselves up more to succeed because there's going to be less resistance to these kind of things. And remember that we kind of got it off easy. I mean, the medical community was impacted quite a bit with a 1.5 infection fatality rate for COVID. The big one, the hypothesis of Michael Osterholm is what would people need to do for something with an infection fatality rate of 10%. And I would argue that people want to protect themselves. So by putting masking at the top, you're really going to be giving people an opportunity to try and protect themselves. And as the modeling that Goja and Joe Eastman have provided, it doesn't have to be 100%. So it's not a dichotomy fail pass. It's a spectrum, and the more people you have masking, the better. But it doesn't have to be 100%. I would love to maybe with you, Sunil, talk through more because obviously we don't have enough time. But where you see the possible points of failure are and how we can mitigate some of those failure points. Because I do think gaming out those possible points of failure in advance would be very useful.
Thanks, Joe. Thanks, Sunil. We'll go over to Annie.
Joe, excellent presentation. Two things that I'd like to talk about is trust and communication. And I think that what you're creating is essential, like this, the idea of doing a large document or a book or something like that. But who is that specifically destined to? I'd like to know. Also, the idea of setting up something like public service announcements, something that like we had in the 70s and 80s, we had water saving things. I grew up in Southern California, so water saving, don't be a water hog. All the kids knew it. How to protect yourself during an earthquake. All the kids knew it. Louis the lightning bug. Turn off the switch when you leave the room. Like these sorts of fun, easy things that become incorporated into people's lives before an accident or a new pandemic or anything else. And I think that looking at ways of building trust in science, which I know we're going to talk about tomorrow, and also referencing the Ebola talk about rumors, the way that we build trust is, I think, essential in this plan that you're putting together. And so I would say from a communications point of view, trusted branding is really, really important here. So if you train people, if you have this, like they see this symbol, you know, like we see Red Cross, we know what that means. We know this is reliable, you know, that gets away from the political angles of it. So I think consideration into how we could start doing that now would be critical to be successful in any of these implementation processes. So thank you so much for this. This is really interesting.
And a couple points. First, you said, who is this for? If I look back at the COVID pandemic, there were pockets of areas that did it right. We even had in Ontario, the occasional, Thomas Piga comes to mind, public health officers who really understood the problem and tried to create plans around that. Again, I'll point out the maritime provinces as doing it right. But they had to invent it from scratch, right? They had to create their own plans. This is what we're trying to do, is give them a off-the-shelf plan that they can implement rather than create. So that's kind of what I imagine. And in the perfect world, it's not the local public health officer, it's the national chief medical officer that pulls it off the shelf. But if it doesn't exist, it won't be used. So that's kind of how I envision the audience being. The second thing you talked about was communication. I will right off the top say that I'm not a comms person, and I do feel the comms section of our plan is weak. We're acknowledging that it needs to have been better, but I think there needs to be better and um, more expanded elements in that comms section. And if you or anybody else wants to help with that, it'd be most appreciated.
I'd be happy to join. Yes, thank you.
Thank you, Annie. We'll go on to Jeffrey.
Oh, excellent presentation, Joe. Very, very important. I have 3 points if I can recommend them. Following up what Annie said, I would refer you to an article that was published in Lancet. I don't know the authors, but they studied 177 countries to see how effective they were in dealing with COVID. And the parameter that most stood out in successful management was trust in your government and trust in your neighbor. So that's partly comms, but it's partly pre-pandemic atmosphere. And I think we have to look at this problem through the lens that we had government incompetence in the United States at the federal level, which was both horrible, tragic, and atrocious. And I would call to mind the fact that in October 2019, there was a war game on the pandemic, which produced a lot of wisdom about how to manage a pandemic. And when the new federal administration came in, it threw out all that knowledge as well as the playbook. So yes, the transition to acceptance is an important component. Lastly, I'll give you an anecdote. My grandchildren were in preschool in 2020, and they were allowed to stay open. And the preschool they went to potted the classrooms and isolated them from each other, required kids as young as 2 to wear masks, and required weekly or twice weekly testing, and essentially was able to keep the school open and safe with no outbreaks through the period of 2020. So on the micro level, your model works.
Yeah, just to echo something you said there, trust takes years to build, seconds to break, and forever to repair. Not my quote, but from somebody called A.D. Ryan. But I think it really continues to resonate that I think we all have pretty attuned bullshit detectors, and there was a lot of bullshit in the COVID pandemic that our public health leaders are still having a hard time recovering from.
Thanks, Jeffrey. We'll go to Joa. Okay, good.
Yeah, thank you, colleagues, and thank you, Joe, for excellent presentation. I just wanted to say that during the last pandemic, especially for us especially for us in Africa, it is allowed to hear all the alerts, and all the alerts are investigated by a group, a team that are specialized. That is a team specialized in risk communication, and that team, once alert is given, they investigate, and they are the ones who are to declare that alert either as a rumor to be stopped at that level, and or to know that it is credible and to continue with the investigation up to end. So at the level of the community, it is not wise to say that that is a rumor or not. So that's what I wanted to raise. It depends on the level of literacy level of the community. But in what we call community diagnosis, if you go to a community, it is you will find that very valuable information will be got from the person whom everybody despises in the community. The reason is that that person tells the truth and nothing but the truth. Is not impaired, is not restricted by, by, by anything. It is what he knows, what he has seen, that he will talk about. And such alerts, if not investigated, we may miss some very important information. That's why I would like to re-emphasize here that investigate by appropriate team or the alerts. Once again, thank you, Joe, for an excellent presentation.
Yeah, and Joe, for you and Sunil, as the two people who've spoken from middle and lower income countries, in our mind, we're trying to recreate a plan that's not for Canada or the US, but could be applied in any jurisdiction. I'll just say that one of the problems I think that the WHO has had is they have this kind of distorted version of equity in that they do not want to recommend, and they've been explicit about this, respirator masks because they feel that uh, developing countries will not be able to afford the 80 cents a week for a respirator mask. And therefore, unless everybody can afford that option, they don't want to make that recommendation. I think that's a very uh, distorted way of looking at equity. I think the right way of looking at equity is if respirator masks are the correct baseline for prevention, then we should be working to provide those masks for all peoples in all countries rather than saying nobody can have them because some people might not be able to have them. I love maybe at another time for you, Joa and Sunil, to weigh in on that conundrum.
If you want, I can respond to that.
Sure.
Yes, but I think me and Yanni talked about the masks at least, in particular, on a number of occasions. And I told him that for once we had the pandemic set in, for 2 years straight, I received an N95 free of cost from my hospital every day. And this was not just me, this was everybody across this country. So we have around 870 medical schools. Everybody in those medical schools got these N95 free of cost.
Better
Primarily
than
because of the
Canada.
fact that primarily because of the fact that the cost of producing those masks dropped drastically. I wrote a paper on that as well, even in the beginning of the story itself. So if the cost of a mask was 350 Indian rupees in the beginning when we started procuring it from outside India, at the end of it, it was being manufactured 10 times at a lower cost. So it was 35 rupees. And eventually it turned out to be 2 to 3 rupees. So once the mass production started coming up, everybody in India was in the hospitals was using masks. My concern with masks is we have again spoken about it on a number of occasions. Masks being used in hospital settings is the non-use of masks in hospital setting is not because of the fact that it is not available, but because of the fact that people are not willing to use it. Mostly the healthcare professionals, they're not very happy to use it. There are n number of reasons why they are not wanting to use it. And if we are talking of use of universal precautions, mask should be something which is ingrained in it, is a part of it. And for that, if you are moving it across the hospital settings in the country, name any setting, low, middle income countries, it's always going to work out. So equity is not the real reason for it. Money is not the real reason for it. I don't see it as a real reason.
Yeah, I mean, that's a problem everywhere. That's not definitely not a an India problem. I'll tell you, in my hospital, if I walk in, um, there's a sign that says, "Have you washed your hands?" for every patient. There's They have people walking around measuring whether you've washed your hands before and after seeing patients, and then you're getting a scorecard. There's a ton of effort that's being put into hand washing that the equivalent hasn't been done for masking. And so it's not surprising that people are pretty good at hand washing and not very good at masking. Again, the other thing during COVID that was never done was an explanation of airborne transmission, an explanation of long COVID, and an explanation of the ethics of infecting your patient with a deadly disease. Those are all things that were never talked about. And so masking was never prioritized.
Thanks, Sunil. Let's go on. I see 5 hands up. We've got a little under 10 minutes, so we'll try to get through all of these. Margarita, please.
Before Margarita starts, just a reminder that I think we're doing an ongoing small group workshop on this afterwards. So if this is really engaged, if we don't get to your question, if you have more deeper conversations you want to have, we can do that in the next hour after this section ends. Sorry, go ahead, Margarita.
I just wanted to let you know that we need to get, I'm a registered nurse by profession, and sorry to say this, but we need to get the heads of all these healthcare settings to start masking and to lead by example, because it also gives a secondary thing that patients see that the nurses aren't masking, the doctors aren't masking, all these people aren't masking, so therefore it's not necessary and it's not the whole education. And then I put things in the chat about getting a lot of people to say go to the mall, and when I've been, say, with my kids and we're wearing our N95s, yes, people have made their comments, but I've also educated them, and they've even then took N95s from me because I always have extra. And even when my son had to go to the hospital briefly, I got in that day 5 people to mask, and they were wearing N95s in the end. So it's an education thing that everyone needs to start leading by example and to be properly educated and making it normalized. That's it.
Thanks for that.
Vicky, please.
Yeah. I just have a very quick comment. I'm a big believer in mask reuse, but with testing, the importance of giving people a sizable reserve sends a very different message. When the US government sent out 4 masks per household, or 4 tests per household, even somebody like me who believes in testing and is willing to spend my own money on testing, there's a kind of assumption of like, oh, I only have 3 left. Maybe I shouldn't bother testing today. I'll save it for a time when I feel sick. Whereas if you send out like 20 per month, as the month goes on, you're like, wait a minute, I'm going to get 20 more in a week. I still have some from before. I should use them. So sending out a sizable number of tests sends a message in and of itself.
Yeah, we had free testing in Canada. When I was in the UK, they had a QR code on their test that you could take a photograph of it and submit it. And that was really useful for pre-event testing. So there were like for the COP 26, we were expected to test every single day while we were at that congregate event. And I'm sure that that saved a lot of infections. So we need to up our testing game.
Thanks, Vicky. Eliana.
Hi, thank you so much. I had a few, sorry about this, my device, a few comments. One is I think it would be helpful for mask promotion to address the actual concerns people have had. Some people have said, well, I got sick because I wore them. It's lack of competency to know how to wear them, and also quality. We've had millions of counterfeit masks come in early in the pandemic. I don't know now about now, but also people talking about allergies to materials and, if they're gappy, just not knowing all of that. So basic public education, as people have been mentioning, like PSAs. But the other thing is, I wondered about any ways to get into the medical systems training. Like, is it possible to have, it's nothing I could do, but I've had thoughts about this for continuing education. Is there a way to set up a free continuing education site where the focus is training on um, health prevention, public health efforts to stop transmission in medical settings and other places? So you get a free CEU and you get all sorts of training that will actually be useful in practical application. And I also wonder about outreach to things like, family education around when people get diabetes, for instance, for type 1 diabetes. At least there used to be nurse and family educational sessions. And is there any way to outreach to these places where there's super high risk conditions like type 1 and type 2, 4 times the risk for long COVID, and represent a majority of, I think 40% of US deaths were diabetics.
Yeah.
So there might be ways to intervene there. And so I just wondered about any outreach to those groups more. So thanks.
Yeah, Eliana, you make some good points. I think we all have memories of people wearing masks under their nose or up on their chin or with the big gapes on the side. Some of that's inherent in the style of mask, the medical mask use. Um, and people say, well, people can't even be taught how to wear a mask. But again, we never tried, right? Like there was never a concerted effort to teach people how to wear masks. And we're able to teach the vast majority, 98% of the population, how to drive a car safely, which is a very complex task to follow all the rules and all the ways of driving a car. If we can teach people how to drive safely, then we can teach people how to wear a mask for sure. But we got to make the effort.
Thanks, Eliana. And we'll go to Rob.
Yeah, thanks. This has been very helpful and interesting. I'm sure Joe agrees with me that it's been a good discussion, and I don't want to slow it down too much. But I did want to say a couple of things in response to Sunil's argument that we should pay attention to possibilities for failure and to the discussion about trust and so on. I think we are really concerned about how flexibility fits into these mandates or lesser nudges. That's part of what's going on in the plan, both for masking, but also it's relevant for vaccines. And I think the other thing I would want to emphasize is that a fundamental issue is a cultural issue that people in authority, the public health establishment, and so on, has to be willing to admit mistakes. That kind of flexibility has to be built into the whole system. And I'm going to stop there because I enjoy listening to everyone else.
Rob, a couple things. One of the things you'll notice that's missing from our plan is vaccine mandates. Because the vaccine for COVID was non-sterilizing, there was definitely an argument as to why they should even be in place. When you, like in Alberta, we had to have a vaccine passport. You showed your passport and you were allowed to go into a restaurant. But because it was non-sterilizing, you could actually get the infection. You could go into that restaurant vaccinated and spread your COVID to everybody in that place. So I don't think vaccine mandates in the COVID pandemic were successful and only served to polarize the population. That may be different if a sterilizing vaccine was available, but that certainly wasn't the case this time. And even if you think of almost all of our vaccines, there's very few sterilizing ones. Even 2 shots of measles vaccine only has 95% protection. So maybe that's something we need to talk through a little more. And your other point, can't remember what it was, but well, oh, that was the
should admit mistakes. That was my
oh, should
main.
it make? Oh, yeah. So going back to these, the both the PHAC plan and the WHO plan, which I've read through in their entirety, they both have statements of we must learn from the past and adjust based on evidence, and then we must use clear language. Both are very explicit about that, and then they don't address airborne transmission, and then they don't use the word airborne or use the word respirator mask. It's in my mind, it's insane. So I mean, you can say all you want that you're going to learn from the past without learning from the past, right? Like.
Thanks, Rob, and thanks, Joe. I think, Ginner, we are transitioning now to the breakout rooms, right? I see Claire and Grace, but maybe they can come over.
Maybe quick comments, Claire, with
And
limited.
I won't reply.
Yeah, you'll be able to respond in the discussion.
Yeah, well, one thing I wanted to point out is that a lot of this is volunteer work, and that shows that this is something that we are interested in because we actually care, right? Talking about building trust, and nobody cares how much you know until they know how much you care. I think it would be helpful if when we're talking to the public, we communicate why we decided to do this, because it's a lot of work, and it's a lot of work that we're not necessarily getting any kind of payment for, not even necessarily getting a lot of recognition for, that we're doing it for a reason. So we wouldn't be doing this unless there were something we saw as beneficial from it. So I think communicating on a little bit of a personal level about why this was even something we were interested in doing might be a helpful part of gaining trust, because it shows that we have some genuine interest in the issue.
All right, Grace, if you want to come on for a minute, we only have a minute left here.
Yeah, just quickly. I really like the driving analogy because it elucidates a lot. We teach people how to drive, but that doesn't happen in a vacuum. We have a built environment that makes it accessible to deaf people to drive, that makes it accessible for people with low vision or lower vision to drive. So I try to imagine, not that anyone was suggesting teaching masking and doing fit testing in a vacuum. I don't think anyone was suggesting that. But I try to imagine someone who's learned everything, got a fit tested masks, and goes to the hospital or to a doctor's appointment, and their doctor convinces them not to. And that's where we are right now, right? We're in this context where you can go into a healthcare environment, and with all the education you might have received from really good health education, the infrastructure we have right now will make it extremely difficult, except for a small section of the population, to do it. That's all.
All right. Thank you, Grace. Joe, thank you very much. And this discussion will continue in a few moments in a breakout room.